So now I'm going to introduce Dr. Jinjun Xiong. He is the director of the UB Institute for Artificial Intelligence and Data Science. He worked on Watson. He's been an amazing collaborator. I see Tim Murphy in the back here, and you helped us with so many things. The CTSA, we're so appreciative. Um, you are going to talk about a little bit about the center, a little bit maybe, hopefully, about Empire AI, and then you're going to lead a panel about the seed funding, right? All that good stuff?
Yes.
All right,
It's a
thank
bit of
you.
a surprise, actually. I have to talk about about the AI and in front of this experts here. And for people who don't know me, my name is Jinjun Xiong, and I'm a professor at Computer Science and Engineering, and I'm the director of the UB's Institute of AI and Data Science. And this organization called IAD actually is the internal organization, and they try to really foster the kind of cross-disciplinary or interdisciplinary collaborations and how to take advantage of the power of AI and data and computing, right, to benefit the different disciplines. And of course, the healthcare is one of the major ones, our focus. And we take a lot of different approaches. I just want to let you know, and this is really a long time effort and with a lot of support from our leadership team. And since we started this effort, and UB has made some great progress, right? And in the past couple of years, we have received some largest grants from the federal agencies. For example, $20 million National Science Foundation grant to establish a National AI Institute and how to apply AI to help children with disabilities. And also, we just a few weeks ago, we got another $10 million grant from the Department of Education. And how do we use the generative AI to help children's early literacy learning? So this, and also we have a few more bigger grants coming and also related to different things. It's all about the interdisciplinary collaborations and how to use AI outside of computer science, and work with people with some domain experts. So that's kind of our approach. And today, and we're going to have some of the panel discussion. It's similar along those lines. That's collaboration between the AI and the healthcare. And we'll talk more about this one later as well. And I just want to talk about the Empire AI a little bit. And last year at the SUNY level, we did a kind of strategical study, and we have many, many threats. And one of the threats is about the AI infrastructure. I'm the co-lead of that one. And at the end of this exercise, we write a report to the SUNY chancellor, say, hey, in order for us to advance the science, in order for us to make sure that AI can be used properly, right? In order to address all of these challenges, academia need to take a lead, right? We cannot totally leave this to the industry only. So academia need to take the lead. And academia probably is a better position, considering about the cost of development and about the uncertainty of this technology. It's an infant, I would say infant stage right now, right? There's a lot of uncertainties. Academia research was the best place to start this kind of AI research. And in order to enable us to do greater work, as good as industry, probably better, we need to also have this advanced infrastructure as well. So that's our recommendation. And I don't know what is the backstory afterwards, right? It looks like the chancellor got convinced and passed this recommendation to our governor. And the governor finally made the announcement, right? And at the beginning of the year saying, hey, New York gonna becomes the first state has the most advanced AI infrastructure. That's a $400 million investment. And of course, governor knows how to convince other people to donate the money as well, right? So the state of New York put $275 million, and other 125 comes from other institute, so that's kind of total $400 million. And because of our kind of groundwork, and what success presumably, okay, and I think we did some of the greater work of the AI, and from the very early days, we work with the U.S. post offices, to deploy the zip code, all the handwriting, right, and into the USPS. And recently, we have this National Science AI Institute bigger grant. So all of the things coming together, So I think somehow people convinced, yes, UB is the right place to be the next frontier for the AI, and that's Empire AI. Come to UB, and we're going to have buildings, and we're going to have the latest, best, and the state-of-the-art AI infrastructure. So that opened us a lot of opportunities for all of us, and we are going to talk about it. Okay, so we are very happy working with Dean Bashar last year, and I have this call for proposal internally. We ask our researchers, right, from the healthcare science, outside of your domain, work with people from the engineering side, come with ideas how AI can help you to make your science better. And out of the many, many proposals, we selected 4. And we give them seed funding, and we did encourage them to collaborate and make a difference. And today we are happy to have the leaders of those 4 proposals and come here and have the panels and the discussions. And I'm going to moderate this panel and ask them questions about their projects. And of course, we'll open up for your questions as well. Okay, so I hope our leaders are here. Please.
Maybe Jill or somebody can talk a little bit about the seed funding. So seed funding came from the VPHS budget and is specifically to seed fund these projects. So we're hoping you all are submitting big grants if you haven't done so already, right? Awesome.
Okay, thank you. So we're so glad to have all of you here. And so before we start, I think why don't we just do a quick intro about yourself, right? And talk about your name, your affiliation, and your area of expertise, and then we can get started. So please.
So I'm Tom Grant, or Thomas Grant. I'm in the structural biology department here at the Jacobs School. My area of expertise is in determining protein structures and drug design.
Hi, I'm Federica Bulgarelli. I am an assistant professor jointly appointed in psychology in the College of Arts and Sciences and learning and instruction in the Graduate School of Education. So quite interdisciplinary, but I study language learning in young infants.
I'm Gene Yang. I'm a clinical assistant professor in the Department of Surgery here at UB with a focus on foregut, bariatric surgery, and abdominal wall reconstruction.
I'm Sabrina Castucci. I'm an assistant professor in the Department of Industrial and Systems Engineering. And my area of research is all health systems, technology, integration, all those wonderful pieces.
Great, thank you. Okay, maybe Sabrina, let's start with you, okay? So I would like each one of you, right, give the audience kind of a high-level summary of your proposal, right, and what do you want to achieve, please.
Okay, so I'll do the short version, but there's a lot going on. So what we're looking at is the problem of, which you may not even see as a problem, I don't know, of looking at how a hospital-based clinician forms an understanding of what kind of the standard care was out in the community prior to that hospitalization. So think of the discharge summary that happens on the back end of this process. We're looking at the front end and how can we improve that understanding to be able to kind of inform the decisions that are happening in the hospital, but also to inform what happens kind of in an even earlier sense of what happens when they leave.
Thank you. Okay, Jenny.
So in terms of the Surgery Video Net project, it's really trying to tackle the current bottleneck that exists for computer vision in surgery. And essentially that's just surgical video and just having a high volume. But getting past just the volume of data, it's really, well, is it a high quality video and is it curated and annotated in a standardized fashion that can be accessed by potentially third-party researchers and industry to continue research.
Please, sir.
So we're interested specifically in a group of infants who are termed late talkers. So these are 9 to 20% of kids between 18 and 24 months who don't meet expressive language milestones. So they don't say at least 50 words by that time. And about half of these kids then go on to have persistent language delays, which we know also impact things like educational attainment, life satisfaction more broadly. But there are currently no real risk factors for being a late talker and then continuing to have persistent language delays. So we're hoping to use some pre-existing data to model if there are patterns in, for example, parental linguistic input that could be naturally protective factors for these late talkers.
Also say one of you about your NSF project.
So I am not part of that, but it is very related.
Yeah. Yeah. Okay, Thomas, please.
One of our holy grails in our field is the idea of structure-based drug design, where rather than just screening through hundreds of thousands of potential drug molecules, you'd actually rationally design a drug. And one of the ways that we can do that is through knowing the protein structure. But the problem is that knowing protein structures is very difficult. It's very time consuming. It can take months or years to do that. And so we're building a tool that allows us to do that with experimental data much, much faster, potentially within days or even seconds potentially. And so the idea is that we can collect something called SWAX data. And SWAX data allows you to do this and integrate some recent developments in AI to allow this to be much more accurate for drug design.
Thank you. Now I know how to say your product name. I was about to ask, Swax Fold. That's the project name. But right, like this Google had this AlphaFold that has got a lot of attention, right? It's probably the second most cited papers, but still some drawbacks. Thomas, can you please comment on it? So what's the impact of AlphaFold and how your Swax Fold will make kind of different from AlphaFold?
Yeah, sure. So AlphaFold is a way of taking a protein sequence, an amino acid sequence, and directly calculating the structure, which obviously takes seconds as opposed to months or years to do. And it's been, a major boon. I think it's been cited more than 25,000 times in the last 3 years. So it's one of the most impactful developments in AI. And it was really one of the first very practical applications of AI in the world of research. For biomedical research. So what we're doing is we're integrating experimental data to make these predictions much more accurate, because one of the major limitations of AlphaFold is that it only predicts a static structure. And that is not good enough to being able to do structure-based drug design. So we're integrating experimental data that is sensitive to dynamics through SWAX and allowing us to generate much more accurate dynamic ensembles of proteins.
Thank you. Okay, Federica, back to you. So your project about the later talkers, I don't know how many people knows about this one, but so why finding those protective factor is important, and how many, I don't know, the children will benefit from kind of early identification of the early talkers? I know it's one of early conversation, right? And they've mentioned about the pre-screening, and screening is very important. So can you please comment on that?
Right. So what we do know is that late talkers are more likely to come from low birth weight, kids who are low birth weight or later borns, but also lower socioeconomic backgrounds. But we have this problem that there just aren't enough clinicians, for example, in early intervention settings to be able to assign anyone who could be at risk for being a late talker to early intervention. And so if we can identify naturally protective factors in parents' speech, which are manipulatable. That wasn't quite the right word. We can manipulate, for example, the types of words that parents say. We can ask them to talk more about certain concepts. And if that is a protective factor for continuing to go on and then have typical language development, we can harness resources where they're actually most needed.
Okay, thank you. I just want to give a little bit more context, that's why Dean Bashir was asking about. So this project, even though it's not directly related to the project we are working on right now, it's the National Science Foundation project. It's the National AI Institute for using AI to help children with disabilities. And we are focusing on how to use AI to help people with the speech and the language challenges. So one of the things we also focus on the screening. And unfortunately in the US, actually, even though we're one of the richest country in the world, in fact, we do not have the universal screening. So this kind of related to Federica's kind of work, and having some kind of the screening techniques AI is very important. Thank you for doing that. Okay, so Ginny, so your proposal, right, looks like handling about the data challenges. Can you please just kind of tell the audience, and I think the data is greatest challenge, right? Everyone talk about it. So can you please, from your experience, what are the challenges that in your practice, right, you are facing, and you think your project can help to address?
That's right. So I believe it's so our hypothesis is really can we address the incentive and standardize the data accrual to accelerate how quickly we can get more surgical videos for analysis. And so one of those issues in terms of incentives is, well, we know that providers or surgeons are recording their videos, and there are institutions that have their own database of surgical videos. But when it comes to more national databases, there's a significant lag. And so it's almost like there's hidden treasure. It's just the inability to connect and collaborate to and have the same terminology and language to be able to have that inter-site relationship. And so in terms of incentive, the whole idea of Surge Video Net is we're almost gamifying the process of data accrual and giving credit for those that are users that may not contribute videos, but they'll be annotating and curating that data. So they'll be getting credit for that. And as this project matures and we receive a critical volume of surgical videos, we'll be looking at commercial opportunities so that we can realize maybe the financial aspect of this by assigning financial credit to the work that's done in the digital common.
Yeah, I find that fascinating. The incentive is always very important. And so I'll come back to you, about a technical approach. So, okay, let's give Sabrina. So, I mean, in the kind of the keynote, right? David's keynote also mentioned about the documentation is one of the biggest pains. And in the panel, we also heard of this again and again, right? And your talk, your work actually is kind of really exactly this kind of issues. And how do you try to use AI to help to summarize this? We call it this hospital admission summary. By the way, that's what I mean. Whenever you do the interdisciplinary collaboration, you want to make sure the terminology is right. That's why I'm looking at my cheating note, make sure I say the right word. So can you please kind of educate the audience and myself, what is the current process of having this hospital admission summary, right? And what are the steps you need to take and why it takes so long? And why do you think AI can help the healthcare providers, please?
Sure. So there's a couple of things going on in that space. So right now, this process kind of happens, right? So we do have our Regional Health Information Exchange Healthy Link, right? So if a patient comes in, you can access their records. And we've seen with that it's a, it's a semi-processed list of information, right? But there's just a list of information. So I've seen some patients that have, dozens of pages of information, specifically when it comes to medications, and then you have to make sense of, what's really happening in there, right? So the idea for all of this came from, a lot of the clinicians on our team kind of do this on a regular basis. Maybe not some in the hospitals, some in like admission to hospice care and so on. And they said, when I first brought up the idea, this is a problem, right? This is a process and it takes a lot of time to do it. Yeah, the information is there. We can communicate information now, but we really, making sense of it, particularly when you have a list of information as opposed to the more in-depth notes, becomes difficult. So what we're hoping to do with this is really to leverage that infrastructure that already exists and to take that AI, and this is again, the multimodal that's been discussed a lot today, multimodal, multi-source data, and figure out how to put a picture together that accurately and meaningfully provides a summary of that patient, which means now it's not just a one size fits all type of summary. It's got to be tailored to a particular patient and their needs, right? So we're trying to be as aggressive with this as possible and thinking about that older adult with a lot of complex physical, cognitive, and even social care needs, if I could speak, and try to bring all of that together to paint that picture. So that's why I said I can give a short description, but it probably raises more questions than it answers.
Okay, that's interesting. Okay, Sabrina, because your background, right, is in the industry engineering, and now you're working with people which is outside of engineering. So how did you find this collaboration, and how did you even identify this specific problem, that you're interested to solve?
Absolutely. So I worked for a while out, doing the manufacturing thing that most engineers do, and then said that was enough of that. So let's come back to school and focus on healthcare. So for the last, 12 or so years, that's what I've been focusing on. But really, there's a very nice parallel, particularly with nurses, because nurses tend to think like engineers are the problem solvers, and they've got to figure out how to deal with this patient issues, right? So it started there, and over time has kind of built up to this really great collaboration with pharmacy, medicine, computer science. There's a variety of people that get involved in these types of problems. And I think that is, so my focus is really on the systems and how do we bring all of these people together to make their jobs a little bit easier, right? So yeah, I think that answers your question.
How did you find the collaboration?
How did we find them? Yes, sorry. So I knew I missed a part. So some of it is relationships that have been built up over years. Others are new folks that I've been introduced with. And one of the great ones was a colleague got me involved with the Team Alice project. And that part, kind of watching those videos and then learning about her story and having some other conversations with folks from other either areas of medicine or just patient experiences. And it kind of brought this idea to the forefront. And, it kind of evolved from where we originally started with all of the input from these different groups. So I guess having nice colleagues to introduce you to people and then just kind of cultivating those relationships over time really helped.
Okay, I wish you had said, because of the AI symposium, this
Well,
is
that helped you. I will say that really helped as well because some of the med students reached out after that with interest in our project. So
I'm just kidding. Thank you. Okay. Okay, Dr. Yang. Okay, so you kind of intrigued us about this incentivize people to share the data, right? So can you please tell people about the specific technology you kind of proposed, right? Especially related to the blockchain
Yeah,
and this is now
exactly.
with the Bitcoin, all of these people thinking, wow, okay, so please.
Yeah, so it's a digital common. So digital common that's based on a blockchain-based digital ledger. And that ledger is to account for users' video contributions, but also for users, again, that may not contribute videos, but do want to curate data. Or if they want to annotate surgical videos, then certainly that will be accounted for within that ledger. So there are smart contracts that govern transactions. So essentially, we're looking at credits at this early stage, so gamifying, but hopefully in the future, that'll turn into financial transactions. And also permission policy so that at each participant node, there's access to say whether you want your contributed or contributions within the digital common accessed by third-party researchers or not.
Okay, I don't know. So, okay, anyone, after this, technology will be interested to ask questions. Anyone? Okay, please. Oh, okay, let's give our keynotes. And Dave, please. Because David doesn't need the microphone, so let's go.
First of all, these are all really exciting projects, and thank you for sharing. I did have some questions, if you don't mind, for each of you, just to better understand a bit more what you're doing. So, Jean, the surgical videos, are these the ones that are done through laparoscopic and the endoscopy type of tools, or are we talking about cameras outside?
That's 100% correct. So actually, one of our innovation fellow has done quite a bit of work during residency to be able to capture open surgeries, to have a camera system to be able to do that. But essentially what we're targeting right now is laparoscopic procedures and specifically laparoscopic cholecystectomy. So we're identifying procedures where we can more easily get surgical videos, but also the procedure that's going to be done most commonly in the United States.
Okay, so one potential collaboration you may want to look at is with the Surgical AI Innovation Lab, or SAIL. I'm not sure if you're familiar with them. Okay, so have you talked to the folks there?
Yes, so our department lead, so yes, we are in collaboration with, or have started talking with SAIL.
Okay, so let me know about that, because the person who is the chief organizer, his name is Dr. Oz, but he's not the Dr. Oz you're thinking of. Yeah, he's from Duke, and so this system has multiple different organizations across the world. So you got Duke, you got Mass General Brigham, you've got many sites across Europe. But they've already got a network, and the reason why I know about SAIL is because SAIL is actually a subcomponent under TRAIN. So we are trying to implement responsible AI through surgical AI. So I'm happy to kind of help you in that process, because it sounds like you've got some very similar activities and it might align well. Question for Federica: the whole concept of late talkers, because you have identified several components, but late talkers are oftentimes associated also with autism and the autism spectrum. And I wanted to get your thoughts in terms of, as you think about how late talkers can diverge into different paths, how that will impact your ability to understand how AI can be a particular factor, because different paths obviously have different pathophysiologies and etiologies and things like that.
Right. So we're thinking about this really behaviorally at this point. So what we are doing is trying to identify features of the input that parents produce to their kids. Specifically, I'm going to give you a concrete example, which is we're interested in shape nouns. Those are nouns that can be identified and generalized based on their shapes. And that's actually one of the things that late talkers who go on to catch up and have typical language development have more shape nouns in their input. And the relation to autism there is that actually kids who have autism are less likely to be able to use shape to generalize. And so this is a feature that's common to late talkers' vocabularies as well as kids with autism's vocabularies. And so we're hoping to just be able to say, using pre-existing data, can we identify a hierarchical causal structure between the amount of words that are shape-based that parents are saying and the words that the kids are saying? And then can we use counterfactual models to say, if we change the amount of words that parents say that fall in this category, does it also change what kids are saying? And then put that into an NIH grant to say, can we actually manipulate this in the real world? So I think we're still, as true basic scientists, a little bit further from what everyone in this room is doing. But these are kind of laying the groundwork for trying to understand those patterns.
Yeah, I mean, I think that's great. And just one of the challenges that I sort of see is that, late talkers can, like, how do you define what a late talker is? Is a late talker someone who, like, if a person never speaks, are they considered a late talker, or are they out of scope? If they, let's say their speech is very poor, at the end, but they're still speaking, but you can barely understand them, are they a late talker? Or, like, are you, so, like, the definitions of how you scope it out may end up kind of directly impacting your results.
Yeah, so right now we're using a corpus that has kids who have been identified as late talkers by other clinicians. But then the plan is to use this model in an NIH grant where we would actually start with kids at 12 months before there's any evidence that they are late talkers, recruit a really large sample so that we expect to see different types of kids longitudinally so that we can really track this and see who develops in what ways.
Okay, and apologies, but I mean, each of these is very fascinating. Thomas, your work is very similar to a lot of the work that we see where a lot of pharmaceutical companies are building out these type of models. And what we've typically found is that depending on which structure you're looking for, oftentimes requires a massive amount of data, supercompute capabilities. Are you leveraging that? And then also we've seen that generative AI has completely transformed the trajectory in terms of your ability to kind of build out these models. I don't know if you've had that experience as well.
Yeah, absolutely. So as you're familiar with AlphaFold, obviously, so this requires large compute resources to train something like that. But to actually run it doesn't require that much, right? That's kind of the whole advantage of it. It only, can run in a few seconds on, a desktop or something like that. So it takes a lot of compute resources for us to train our model, but to actually run it is a much simpler task. So what we're hoping to do is to be able to develop a large database, much, much larger than it was used for what AlphaFold was developed on. So AlphaFold was developed on something like 200,000 known experimentally determined structures. Our data, SWAC's data, is extremely easy to collect. You can just sort of make your protein sample, send it out, collect data. You can collect thousands a day potentially, and build up a database of millions potentially of experimentally determined structures. And so our hope is that in doing so, we can capture all of these large scale dynamics. And so yes, in that case, you're really requiring large compute resources to be able to do that scale of learning.
Yeah, that's fantastic. And Sabrina, last question here. One of the things that I heard from some of my colleagues who are chief medical officers for large health systems, they are trying to leverage AI to do these summaries, but they oftentimes find some really pragmatic use cases even beyond hospital discharge and summaries to help the clinicians and patients. Things like when there's a joint commission review, you've got a small team running around the hospital trying to find patients with certain things. But if you could run AI and find these and summarize them and extract the information, you could really build a capability so that the individual teams could be much larger in terms of their scale. So I mean, some of the stuff that you'll be building could actually have significant other opportunities beyond discharge.
Yeah, we agree wholeheartedly. And like I said, where we started was a bit of a different discussion, right? So even, kind of helping folks who have, folks who are adopted or are estranged from family members, if there's still agreement to share some information, how could that happen, right? That was really where we started with this conversation. And so what we started to see all of these different opportunities, we said that, there's some really fundamental questions that, from a systems perspective, haven't really been studied in a long time. So this idea of how do people form an understanding of a patient, the best we could find from data on this from a kind of a human factors or performance perspective came about with the advent of EHRs. So no one has really studied this problem more recently with, now that we have not just EHRs, but health information exchange, all these population monitoring types of programs. And how does that really change how this task is done? So that's where we started. We said we have to first understand the task. And once we are kind of building this prototype and getting the systems in place, right? So our first grant, even that we're putting in a few weeks, is just about the data exchange portion of it. Once we get those pieces in, then we can, build our prototype, answer some of these fundamental questions on the data, and then take off from there, hopefully.
Thank you. I think there's a question in the back. Yeah, please. Okay. Okay.
My name is Trevor Insminger. I am a master's student at the School of Industrial Systems Engineering with a concentration in data analytics. And I heard Dr. Yang speak about the data problems he was having and the bridges that you guys are trying to have with the data and the AI. So what were the biggest challenges that you are facing so far? How are y'all moving around it to say so far at this point?
As reference, I think it's just collaborating and developing larger video databases outside of individual institutes and individual healthcare systems. I think as the computer vision and surgery continues to blossom, one of the things that will be interesting is international law and how are we sharing data across different countries, especially as reference, Europe has GDPR, and they're very, very protective of their patients to the point where consent for data collection requires explicit instructions on what that data is going to be used for in the present and if you're going to use it in a future application that requires an additional consent. And then you come to the United States where it's a little bit more complex, where it's essentially it's centered around HIPAA, but it's institution to institution is a little bit different, state to state is a little bit different, and unfortunately country to country is a little bit different too. So currently it's just working around that, but also at the same time concurrently working on, well, where is our understanding of the legal and ethical aspects of patient privacy, surgical data, and how are we going to use this and consent these patients? And that's I would say the biggest push right now. And then probably on the back end of that, or also concurrently working on what the legal aspect, right? So what is the legality and liability for these AI models that are being made from this? But so sorry, long answer, but to answer your question, it's really working in collaboration with multiple different sites and other groups that have an AI initiative, but there is still plenty of work to do in terms of maturing our understanding of where AI and healthcare fits, both in the local and regional level to address that fully.
Okay, thank you. More
So actually, I have a question. And if I have the mic,
please.
just go right ahead. So one of the components of the seed funding project was that you had to be working with collaborators outside of your school, like across the university and outside of your discipline. So this is the direction that we all want to go in, building interdisciplinary teams. You know, Dr. Bashir, we talk all the time about how do we build center projects and get people to collaborate more. So can any of you share your experiences, or offer some advice to early career people who need to connect across campus? Like, how did you go about doing that?
Maybe Federica, you want to start first? Okay.
So I've always been part of interdisciplinary spaces. My PhD was interdisciplinary at Penn State, and my role here is interdisciplinary across decanal units. So I think I've been lucky to have just grown up in those spaces, which suggests to me that the academia generally is moving in that direction. So my collaborators on this project are Allison Hendricks, who is in the Communicative Disorders and Sciences department, and Ifeoma Nwogu, who is in computer science. And so I actually was lucky to know Allison in grad school. She was in a completely different department from me. We were years apart, but when I got here, we started talking again. And then she knew Ifeoma from the NSF-funded HEI and education project.
Alison is also on our team, by the way. So.
So I kind of got lucky because I had these connections and I was able to leverage those. And so I would definitely, if you are still in your degree program, think about how the people you know now can actually connect you to new people in the future at times when you're not even sure where you're going to be, but these connections are worth making now and holding on to.
Okay, Thomas.
Yeah, so I am a mathematician and physicist by training. So I don't know anything about medicine. Don't ask me your questions now. So a lot of the developments that we've had in drug design and in AI, I don't know anything about AI, or I didn't until this whole thing started. And so I collaborate now with Zach Falls and Ram Samudrala, who are in the biomedical informatics department. And they're very expert in AI and using AI for drug design. So that was how I was able to connect with them for applying this project. Yes. I'm in the Jacob School, and they're in biomedical informatics.
I'm both College of Arts and Sciences and education, Graduate School of Education and engineering.
Oh, clever. Yeah, exactly. So I can speak actually kind of from the exact opposite side. So from a clinician scientist. And so I would say for those starting out, I think there's plenty of opportunities. And I think this is just a perfect example of if there's interest, there's a way to get through it. I think the special part about clinician scientists, and I would say from a surgeon scientist aspect, is it has to start early, as early as possible. That long are the days where one surgeon could, or just an individual medical professional can really do all the work by themselves, and it really requires a team behind them. And with how complex research is getting, it really most research requires an interdisciplinary approach. So I would say it's really the strength of the mentors that will get you to where you want to be. And then for me, that was really Dr. Schweitzberg, the chairman of our department. And this is something that he's always had in his mind. I think if we look at our research tracks, we have a track for MPH, bioinformatics, biomedical engineering, MPH policy, but these are all things that have really blossomed because I had a mentor that identified that if I was interested in research and if I was going to be successful, that I had to start very early. And for me, that was starting in residency.
Sabrina?
So again, coming from industry, right? I was, as an undergrad engineer, right? You are in a room with everybody like you, and you kind of think the whole world is that way. And then when you go to work, you realize, no, in fact, it's the exact opposite. You're the only one that knows what you know in that room. So it became pretty natural for me to get comfortable working in an environment where everybody knows something different in that space. And you grow to appreciate the fact that there are people with different perspectives. So when I, again, looking at things more from a systems and an organizational level, you realize that if you're going to do what we set out to do, then, our team needs to be even bigger than it currently is. But there are, I want to say 7 of us on the team, and that's enough for 1 year, right? And a lot of us are collaborating, kind of subsets on other things. So we have, I think over the years, again, it takes time. And as you were saying, you don't necessarily know who you need to work with in the future. So you need to start building those relationships early, if nothing else, to get their perspective and to learn. And then to build that into eventually long-term, we can all work together because we're working towards the same vision.
Okay, thank you. Maybe another questions? Yes, please.
This is a question that I really have been thinking about since this wonderful day began. And there's a word that I heard 3 people use, Dr. Rue, Don Boyd, and I think Sabrina, you used or alluded to privacy, and maybe you did also when you talked about HIPAA. I'm Nancy Nielsen. I'm a clinician. I'm Senior Associate Dean for Health Policy here at the Jacobs School. We live in a country where Americans have vigorously resisted having a national health ID identifier. We are extraordinarily protective of privacy. And so we have to keep these human factors involved. I'm thinking, I think you have incredible projects. I can't speak to protein folding as a privacy issue, or so much to the surgical videos, but boy, a lot of other things. Just think about a discharge summary. You have somebody who may not want you to know that they have an adult son who's a felon who lives in their home and is going to take the controlled substances. These are issues. These are the real issues, and I just I want to raise it because in our country, as I learned when I was at a conference in Copenhagen, and I asked, aren't you guys worried about privacy? They said, unlike you Americans, we trust our government. Not true. It turns out it isn't. But I just raise that issue because those are the human issues that are going to complicate. It's one thing to have parents who are worried about a kid to bring them for a study. It's another, if I knew everything about every patient who came into my office, I could have done a better job. But there were things that were secrets.
Thank you. These are good comments. But let's kind of, I mean, these are great comments. Okay, but let's try to bring this panel to the conclusion. So I just want to ask each one of you, identify like one of the wishes, right? Like, hey, if I wish technology, or if I wish the Empower AI give you the computation, or if I wish something, what is the wish you would like to have? You know, so that way your research will make a difference. Maybe start with you. In one sentence, exactly.
I can do 2 words, computational resources. It's the single biggest limiting factor for what we're doing.
That's Empower AI. So your problem solved. Okay.
For the type of work I do, we've come a long way with natural language processing, but we are not yet able to reliably transcribe speech from children or in context when there's tons of people and background noise. So it sounds like we're getting better in like clinical spaces, but in the real world, that's still not there. So that's what I would love to see.
Yeah, automatic speech recognition for children with disabilities. Dave, something look at you now. Okay.
I'd say my wish would be, it's just following on that comment on how do clinicians get into research. I'd say if you get lucky, you start off early, you have a great mentor. I think, but certainly you go in the hospital, there's plenty of people that are interested in research that have absolutely no idea how to get started. And unfortunately, a lot of these are early stage clinicians. And so I'd say just continue to support those and find ways to financially support those early stage research clinicians.
So Bashar, that's you, right?
Yeah, that K-12 grants, a CTSA, and programs like this. Awesome.
Okay. Thank you.
So I actually have to say my wish aligns with Nancy's comment very well. As we are getting into this problem more and more, we are finding that, there are the data sharing limitations, meaning, just the many organizations that are participating in this and doing so, and putting, just the approaches that they take and how just a philosophy that a company adopts is impacting how we can share this data, what we can share and with whom. I wish we could overcome that. There's cool things happening, I think, that might solve this, but hopefully not before they review my next grant.
Great. Okay, thank you. Thank you all. And thank you so much for participating and enjoy the.
I got it, Mike. So that concludes our program. I want to thank Dr. Rue. I want to thank Jinjun, who's a wonderful collaborator. I want to thank the rest of our panelists. Really appreciate it. We actually have food outside to the point of relationships and breaking bread and stuff. So we will send you a survey. I would be remiss if I didn't ask you for a huge round of applause for Dr. Cizak and her entire team. And never leave a meeting without the next steps. So number 1, you have a survey. And number 2, when is Dr. Volka, when is she coming? April 1st. And who is she?
Dr. Volko is going to join us on April 1st. She is the director of NIDA. So we're very excited that she's going to be making the trip up to Buffalo. It's not virtual. She will be here.
Yeah, so she's the director of the National Institute for Drug Abuse, and she's going to be here in person, which is incredible. So thank you to Jill for facilitating that. Enjoy lunch. Please fill out the survey, and please be here on April 1st. Not April Fools, trust me. Thank you.